It's Roger Green, host of the Surfing NASH Tsunami podcast. This week, all our posted conversations contain completed contents from our year-end interviews, edited only slightly for flow and background noise. This conversation is with our good friend and former co-host Donna Cryer, founder and CEO of the Global Liver Institute. Donna discusses some of the major advances patient advocacy has made in 2022, all in the context of an exciting year of guidelines, drug and device development for fatty liver disease. Just a reminder, Surfing the NASH Tsunami will have next day coverage of the 2 presentation days at NASH-TAG, posting the Friday session around 6 p.m. Saturday Eastern U.S. time, and the Saturday session around 6 p.m. Sunday Eastern U.S. time. And here's Donna. So this conversation is part of the year-end ritual called Getting the Band Back Together. We have Donna Cryer with us. Hey, Donna, how are you? Welcome back.
Donna Cryer.
Hello.
After a highly eventful year, Jörn decided to stick around because he just wanted to talk to Donna, despite the fact that it's now 10 o'clock in Germany, and he's got a busy couple of weeks ahead. And then we have Louise.
Well, I do want to say that we have NASH materials in German. We have team members who have been over to Germany, and we are conversations with the German embassy here in D.C. So more to come on that partnership from the GLI angle. A very important relationship for us. You're, of course, giving us the inspiration for that.
Jörn Schattenberg.
That's so exciting, and I hear you, Donna, and we'll see how that plays out. But that's about next year's review then, I guess.
That's right. Danke.
Donna, how much do you have in Turkish?
I believe all of our NASH materials are in Turkish, in Arabic. They're in 16 languages. All of our NASH materials have been translated. We're working on our liver cancer materials and our others, but all of our NASH materials are available in 16 languages, including Arabic, Turkish, and German.
Because I'm mindful that the first time that the two of you were on together, you and Jörn, that the subject of Jörn not having Turkish materials came up.
That's right. And Donna's team sent them to me, and it's something I'm using today just to highlight, what's fatty liver here.
Fantastic.
So with that, Donna, tell us about your year. And as you come to the end of it, what are you looking forward to?
This is a year of, as much as of it has been activity, it's still preparation for an even bigger year next year. So as momentous and as full and as robust as this year, the urgency of it to prepare the ground and the field for our hopeful approvals next year gives it a real importance of a year.
How has that manifested in terms of your planning and the things you've been working on?
I think it has been, certainly I'm grateful for all the roles that patient voice, not only my voice, but the voice of other patient advocates have been invited into. So all of the different processes that when I started into the field of patient engagement didn't exist. I have German on the mind, so I wanted to say they were verboten. But from involvement in developing guidelines to certainly nomenclature discussions to quality measures to helping all of our members of the GLI Liver Action Network put on screenings and clinical trial recruitment. I think the diversity of efforts that GLI and GLI patient advocates and community organizations under our banner have been involved with have just never been more as diverse and as extensive throughout a field as they are in NASH. And so upskilling advocates and capacity building for the organization to be available in all of these places and to be able to make meaningful contributions in all of these areas is where I have focused. So when I look across, and it's available, I believe now or as of the airing of this episode, our 2022 U.S. NASH Action Plan snapshot that actually does incorporate some other non-U.S. actions as well. It really is, to me, stunning in the diversity of activities across stakeholder groups that have been activated for NASH. So I hope everybody really appreciates how necessary all elements of the ecosystem are and how we have been building up this momentum in NASH that's been so necessary.
You say snapshot, and I was actually one of the questions I had on my list for you was to show us 3 pictures, not literally because we're on audio. The specific things that have happened this year, where 3 or 4 collectively paint a picture of the breadth of what you're talking about and the best moments.
Just if I cut in, I don't want to take time of Donna's review here. I think for me, if I think back of the year and the patient engagement, the voice has become so much stronger through the work Donna and her team have been doing as a physician. At all all levels, whenever we meet, discuss the name changes, we discuss therapies, we discuss clinical trial design, we discuss what's important for the patient, which seems logical, but I don't think that has always been like that. And so I perceive as a physician a strong momentum here, which is to the goods for the field and for the patients, of course. So congratulations, Donna.
Thank you. So Roger, you asked for 3 examples. Taking the lead on response to ICER's scoping documents, or involvement in health technology assessment, and being very, very involved in there, and now being reviewers on that process is one thing. I think that certainly International NASH Day growing to 78 partners representing 71 countries with 22 endorsements from scientific and medical societies worldwide is important. When we talk about job one being awareness for the field and really convening worldwide so that there's one voice around NASH is something that I'm really proud of the team being involved with. And I also think things like being involved in co-authoring a paper for the National Committee for Quality Assurance. So again, looking down the road to quality measures. So as we put guidances and pathways and things in place, hopefully in anticipation of a drug treatment coming out of FDA, having all of these points, including quality measures that really are necessary to have meaningful access, not just something approved and generally theoretically available, but actually getting to a person is really something that is often overlooked and underfunded and done maybe too late or not at all in so many fields. And so I'm really proud of the field and the organization for coming together, and for certainly appreciate GLI being involved in all of these different ways, sometimes in the leadership position, sometimes just cheering on from the sidelines, but making sure that systematically all of these elements that are necessary for meaningful access are either put into play or now we're really seeing, accomplished.
Louise Campbell.
What I've been amazed with this year, Donna, is that GLI is creeping into lots of new facets. It is becoming its own entity in that concept, and it's driving. That to me is very exciting. You mentioned NASH Day with the amount of partners. It was nice to see, I think it was Hepatitis Brisbane or Queensland Hepatitis were there from Australia. It would be great to see the Australian Liver Association next year and getting more into that. Obviously that's a personal perspective from mine, but also the work that training advocates that GLI works so hard for in the patient advocacy setting, and it's just growing from strength to strength. All of a sudden it's like doubled. It's like cells splitting. It doubles, and it's just absolutely fascinating and fantastic. One of the ways that I suppose I saw that in the flesh was I had the privilege to meet you and Roger and Jörn at Barcelona just after we'd all come out of the pandemic. And obviously that was about putting in pathways and trying to develop that network, and then that recognition and the stuff that you brought about all of the partners you already have. We're not reinventing the wheel. We are building on the strengths of institutions like yourself, GLI, and again, people coming to that table and for that discussion. So I think for me, that's where I can refer people to look at the documents now in multiple languages. That's where we can look at those strengths. And it's a testament, because you do have a fantastic team. I've had the privilege to meet many of them either virtually or in person. You are as strong as the team that is around you, and you build that team stronger. So for me, anything that builds liver disease and the awareness moving forward, or poor liver health, because as we know, a percentage of people will get liver disease, but the majority, as you say on the website, 1.5 billion people actually have poor liver health. They don't all necessarily have liver disease yet. So let's stop them and let's prevent the metabolic health that goes with that if we can. But it's been a privilege to actually just watch from the sidelines and see that development. So I echo Jörn and Roger and a lot of people that listen to this and say thank you, because the patient's voice is now a very strong voice and growing in strength and partnership, not just in liver disease, but in other diseases.
I really appreciate that. And we are so excited to be able to make good on the vision that I've always had to launch our Liver Health is Public Health campaign in the UK to start. And then Giacomo Donini, the head of our EU efforts, really was behind our global health report that gave snapshots into an increasing number of countries about how they are dealing with liver health and where the gaps are in. I think that will create an even larger space for conversations around NASH and allow us to position it optimally. But you're right. The organization is as strong as the team. And I am very honored that people choose to dedicate their careers to, at least for whatever time I'm lucky enough to have them at GLI, and to grow with us. And people are committed to this vision and share sort of a little bit of outrage that why aren't more people talking about liver health? Why isn't that a priority? And bringing in new skill sets to apply to this cause. We need it, and we'll absolutely be reaching out to Australia. I'll ask Giacomo to put it on his hot list. I think also part of our pervasiveness of our work, I see success in other organizations proclaiming that they are now changing their strategic direction to liver health from liver disease. We see even some titles within some industry partners now changing to Director of Liver Health. So I also see that as part of, the effect that we are having on the field as a whole. I think when we can normalize and in fact make it a positive thing for people across stakeholder groups to identify as being on behalf of and being connected to liver health, then that's really that long-term change in culture and conversation that will make all of this work sustainable.
First of all, fantastic. I wasn't aware that there was anyone in industry that had a director of liver health. I think that's exceptional because, as everyone points out, people think industry makes all their money on sick, not on healthy. So that's really excellent. Have you had any surprises this year? Anything has happened that was bigger, broader, zestier, more exciting than you thought it would be?
Zestier. Oh, I spent several hours driving my mother around for Thanksgiving to see her grandchildren at my brother's in Pennsylvania. And for whatever reason, I recognized that whatever story I was going to tell her about whatever skill I deployed or growth opportunity, we'll call them growth opportunity I had during the year, it all came back to nomenclature. It was certainly not anticipated when I put together my 2022 plan, the amount of time and personal attention I would need to spend around this issue of what do we call the disease. I think I've been pretty clear going on record. I would rather spend the time on curing the disease, treating the disease, getting the pathways in place. If all of this money, time, attention, and energies were spent in these areas, I think we would be better off as a field, but be that as it may. So that was my surprise for 2022.
Do you think you're going to spend less time discussing that in 2023? There is the question.
I'm just going to tell you right now, yes.
Be warned, everybody.
We'll take your word for it. So what will take the place of nomenclature?
Our new VP of policy, he's a pharmacist and another attorney. He has experience at AHIP and Avalier. We are working with Jeff McIntyre, another friend of the podcast, and calling in all of my favors and friends for our sort of NASH regulatory conversation as preparing the patient engagement, participation, testimony, reviewer in anticipation of an approval next year. There are so many steps leading up, and then there will be so many steps, hopefully, immediately after a drug is approved. I think that anybody who hasn't sat on a Friday afternoon or evening waiting for FDA to drop an approval and then all those actions to happen really quickly, we'd be happy to train them and prepare them for what cascade of communications, of working with payer partners, hospital partners, clinician partners to ensure that, because the questions will come in immediately from patients. Do I have access? Can I get it? Does my doctor know about it? Can I call my doctor's office? And so we want to not act like we're surprised or this is the first time or we don't know what's going to happen or how this is done. We do. And so preparing for that to roll out as smoothly and as robustly as possible is one of our top priorities, even in this last part of 2022, to start preparing for 2023.
So I have to tell you a funny story. I had a conversation with a major pharma that is stepping aggressively into this space, and they asked me what was going to be different about liver, about NASH. And I said that I thought that the patients were going to be better prepared for access and that access might be surprisingly smooth. Not smooth, but surprisingly smoother than what anybody expected. They looked at me like I was an idiot, not a look I'm accustomed to. How can that possibly be? That's never been. I told them that's because no one had ever mobilized from the patients on up.
Mm-hmm. It's interesting. I had a conversation Friday night. I think that's right. Thank you. And I strive to live up to that. And I was talking talking to a venture partner for a company in the liver space, as it happens at a dinner Friday night. We talked about the difference of going into this space, in the liver health space 10 years ago, and the difference now, and the billions of dollars of value that we're creating and how we are de-risking the environment with our presence and preparation for investment in liver health. That is an essential part of access that perhaps is undercounted in the work that we do and the value that we bring to the field. It's very different launching in a field. If you look at, oncology, if you were going to launch a prostate cancer drug or a breast cancer drug, try not to pay for that. Try not to, and the response and the robustness and the sophistication of advocacy responding to denials of access. And so we have learned, studied, are friends with many of those people, and will absolutely be applying those things and have those relationships on the payer side and on the access side to really make sure that NASH patients are not ignored in the way that they have been previously.
Do you think, given the experience we had with hepatitis C and the drugs being kept at a very high price, do you think there will be a sense of frustration depending on the cost once approval comes through? Will there be some anger, some frustration if we come across the barriers of cost?
One, I don't think that even the initial pricing of the drug in the U.S., and I'll talk about U.S. versus, what it would eventually be in non-U.S. markets. But in the U.S., I do believe that industry and hopefully their consultants have listened to the counsel that do not price it as if you are curing something, because you are not. Price it as if you are going into a polypharmacy environment, because most patients will be on multiple medications. Price it in the fact that likely patients might have multiple NASH drugs to deal with the multiple mechanisms. So if those considerations go into the pricing formulas, and a fair price with the data that supports the overall value to patients in the communities of stopping progression and then the other benefits that we've seen across the different types of NASH drugs, then there shouldn't be any problems with price. And the conversations with payers, they understand that this is not a Hep C situation, that restrictions based on people already having cancer and being near death will not be tolerated. So those are not the conversations that they're having. We need to adequately characterize and profile, people's different risk stratification and comorbidity profiles, and match the treatments to those patients, from the vast number who may need more dietitians and structured weight loss program to those who need bariatric surgery and those who need the addressing of their other concurrent diseases, and then those who need NASH drug therapy. So I think if we're transparent and honest as a field, and one of the things that my husband always says is that hepatologists are definitely the kids that have done all their homework, and we've definitely done the work as a field. And so the science that we are bringing to payers and others is very robust to justify the value and the prescribing of these medications. And so I don't think that there'll be a pushback if everybody has proceeded as we've all been working together to do, and have a price that advocacy can support and the data on value. And then we can just work on highlighting the screening that you do so that we can identify all the patients who need it. That, I think, was actually going to be the larger challenge, starting to really be serious and robust around screening and integrating that into primary care, into community care and practice, so that everyone who appropriately should be on medication gets the medication. Because the story of hepatitis C, even today, is that people, even if they are covered and diagnosed, are not getting treated. And so we can't have that happen in that.
Yeah, you're right. And we are getting in a position to be able to do that. It looks very much like NICE are definitely now going to approve FibroScan for access for GPs in primary care. How we put that pathway in place will be a different conversation. But actually, to be able to access a liver FibroScan instead of waiting a year to 18 months in some areas within your local area should help us get those sort of leaps and bounds and start to find patients, even if it's only in the liver pathways. But it's a start. start. And it's a great leap of faith by NICE if that final approval comes in the next couple of weeks. And it'll be a great start to 2023, certainly also with medications being approved. I'm encouraged by 2023 and the growth that I see and the work that you're doing in that. So it should be a very good 2023, I hope.
Donna, let me follow up and ask about the aspects you discussed around pricing and efficacy analysis. It doesn't cure. How strong is the importance of quality of life in your experience? What do patients maybe expect? And are we overrating improvements in quality of life during the short treatment? Or is this something we really have to put more into the focus? What's your thought? And maybe what did you learn over the last year?
I think quality of life is hugely important. I think that being better at measuring that is the challenge, both clinically, quantitatively, and economically. One of the things that strikes me most, that just leaves me heartbroken most in NASH and patients with chronic liver disease are when they advance to different complications, ascites, varices, and hepatic encephalopathy. If I hear one more spouse or caregiver who's had to quit their job because their spouse, their patient, has started to exhibit their symptoms and they can't be left alone, what is the value of that? That's quality of life for an entire family that might, drop economic rungs because the person is so affected and untreated. So I think we need to paint that picture better and have a stronger narrative around that. I also I was out all last week, so I talked to people last week. So I spoke with someone who works in healthcare, but also had a patient experience, and they got on the right treatment and their energy doubled. They came back to their job, told their boss, they're like, okay, the good news is my energy is doubled. They hadn't realized because it had eroded so slowly, always resetting a new normal, like how tired, how fatigued they were and how it really was affecting them until they got appropriately treated and were like, oh my gosh, this is the energy. This is the person that I could have been all of these years. Now, the joke was, could his team handle him at twice the energy? But that realization that his personal productivity and how that, again, impacted everybody who worked with him and certainly what he was able to then give to his family. So when we talk about quality of life, I think that we need to do a better job of measuring and communicating the impact of these changes that can occur because they are meaningful and significant.
Maybe these are the benefits from getting a drug approved. You alluded to earlier about dietetics, is the fact that if we get drugs approved, there may be roles for social workers within liver units and care and education for carers in hospices or homes that just help daycare, release and respite, because there's very little skill set for encephalopathy within those homes. But I've said before, and I think you say it very well, is that any form of liver disease is not a person-centric disease. It affects the entire family. And where people have to give up work, people have to change their jobs, that's a huge loss of resources to the country. So we do need to look at that wider infrastructure, and maybe that'll be one of the benefits of getting a globally approved drug that addresses one of the biggest global diseases, is that we put in that infrastructure.
And I think that's definitely the conversation. I spend a lot of time at Future of Health conferences, which need to be the present of health and are in some places. The conversation is very much around value-based payments and a benefit structure that pays for food or transportation or things that aren't strictly clinical but play a large role into the outcome of the patient. And so that and the extension of advanced practice practitioners, nurse practitioners, community health workers, and just really rethinking what the healthcare quote-unquote workforce looks like to be able to include health coaches, preventative medicine specialists. I think that there are a lot of folks that can be marshaled to this, reimbursed in a different way, and also jobs that can be created that in and of themselves improve the economic health and vitality of a community by having more people who are in health careers and health adjacent careers who are often the informal answer of questions because they have the trust and credibility of their community members. And so I think both more expanded holistic benefit design and more diversified, expanded workforce are certainly trends that would benefit the NASH space and the NASH patient and liver patients as a whole, but particularly NASH patients who need a very personalized type of plan depending on where they are and what their concurrent diseases are will benefit benefit a lot from those trends.
When we've had discussions this year and we've asked people, so tell me about 2023, and everyone's talked about drugs, I've done something that's a little bit like what you're doing right now, which is I've talked about the resources that drugs will turn loose, and specifically the energy of investment, and that we'll wind up educating everybody because there'll be people now to pay for that investment. You're already starting to see signs of it. Someone talked a couple of weeks ago about the idea that in the States, LabCorp will now reflex an ELF test if they take a look at your CBC and find off FIB4 that there's an issue. To do that reflexively is like a different thing, right? Because you now take some decisions out of the hands of primary care who might not be educated yet and might not be educated soon, and give them a lot better tools to work with. Where are you seeing signs of that kind of thing starting to take shape?
I think they absolutely are. We've had discussions with health systems and EHR providers about putting in that type of alert system or cascades of care. It has to be a priority to make this easier for primary care, to make this simpler for them. You know, we've been beating that drum for several years now. And I give Mike Patel, who is in Canada and is the new chair of our Liver Action Network for the primary care and NAFLD Summit that he just did. And it's exactly to surface those needs and those solutions. I think we'll also see some coordinated care support models that not only give an alert for the next set of blood work, but will help to automate whether this patient should be referred to a dietitian, or, you know, what are the next sets of treatments or counseling or coaching or services from inside an institution, if it has the variety of resources, or what needs to be sort of stitched together throughout various technology, maybe a mix of technology and community-based resources. But there are definitely those companies coming into that space and that work being done.
It's been a great year, and I'm really excited to hear the things you're moving forward into 2023. So I don't think I even want to see this as a finish for you, the year in review. I'm too excited to learn, what your team is planning for 2023. And in particular, when you mentioned, we're ready to counsel whenever there's going to be a drug approved, whatever drug that's going to be, how long it's going to take. There are going to be so much questions around that for the field, for the patients. And it's good to know that somebody's thinking about how to support physicians and patients to get this where it should be.
Absolutely. Thank you. I feel, very blessed as I talk to, I meet monthly with our interns at GLI. We have interns, young people from around the world who are some are in college, some are in graduate programs. And one of the things I say repeatedly, I'm sure I say a lot of things repeatedly if you ask them, but one of the things that I want to make sure I mention is how my career only looks, intentional in retrospect. The fact that I've spent time at payers and at a clinical trial recruitment firm and a PR firm and building policy shops were not intentional decisions that, someday I'm going to lead a global patient advocacy organization and I'm going to need these different skill sets. They were simply following interests and curiosities or insights or passions I had at the time, and certainly opportunities that I'm very grateful for. But to be able to apply them to this liver field that is so far behind many others, breast cancer, heart disease, is, there's such a great need. There's such a great opportunity. I feel an urgency every day to meet myriad needs and to try to, scale fast enough to meet them. And I'm just grateful that I had a breadth of experience that at least gives me something to be able to interpret and hold each of these needs as I construct the team around it. Because the other day I was sitting with one of our A3 advocates as he was expressing his ideas and thoughts, and I was taking furious notes, and I had to take a breath and just tell myself, you don't need to do those all today. But they were all very valid, and they were all needs, from medical textbooks information to how does he pitch himself to local broadcast television and the media skills that he would need. And everything that he was asking for and thinking about is something that I would love for either GLI has worked on and just needs to get out there a little bit better, that we have those resources, or something that I put on the interminable list of things to do in liver health, or excite some other organization into doing them. But it just strikes me that the need is great, and it's a privilege to be in a position and to create a platform to meet them.
My closing comment. It's going to take that last thing you said. It's been our privilege to get to spend so much time with you over the last 2.5 years and watch this whole amazing thing happen. If we come back at the end of 23, what will be the one month thing we will take a look at and just go, holy smokes, Donna, you've done it. You guys have done it again. What will the it be?
I think it would be sort of a package about a drug is approved, there's no access to it, and we're really just focused on the screening and getting people to the treatment. If that process is as smooth and seamless as possible, that's job one. What I would like to throw out into the universe to manifest as my Christmas wish or wish for 2020 is a celebrity, that we've made it so safe and so wonderful over here in NASH land versus Nashville, which I also love, that someone feels, someone of note and notoriety wants to lend their voice and image and celebrity to this cause. That's what I would really love to have, to someone to step forward on behalf of liver patients, on behalf of NASH patients, and say, I'm with you, I stand with you. And so that's my wish.
I only wanted to support all of that. And for all of those people who don't know they've got liver disease, who will be told that they get liver disease next year, they have GLI behind them and they're going to find GLI and will just use it as it should be used as a patient group, but also that it's there and does what it's supposed to do. They don't know the hard work that's gone into building it. They just benefit from all of the work that's been done and all of the future patients to come, because that's ultimately what you've built, is that network and safety net for most of those people who are just going to benefit greatly from that. So thank you on their behalf and mine, because I read all of their stuff too.
Thank you, Donna, for joining us here and giving your perspective. Again, it's unique, and I'm always excited about what's going on.
Thank you. Thank you all, and thank you, Roger. And it's been a pleasure to watch you grow and this podcast grow as a resource for so many in the field. You've done a remarkable thing, and I want to honor your choice to spend this portion of your career on elevating NASH and this issue. You're an essential part of awareness and information and credibility of this field, and I'm so excited that this podcast and this communication continues to grow.
Thank you so much for that. I've been fortunate to have Louise around since episode 5, and Jörn for the last year, and Stephen for the longest time, and you. Invite me on in about 3 months to GLI Live, and I'll talk about what we have coming. Okay, I mean, the one thing I've talked about a little bit on the podcast, although you and I haven't, is the Rising Tide series, which will kick off in January, and we'll go 12 months next year, and we'll have the goal of educating frontline diabetes treaters about why they want to be thinking about fatty liver and how they want to think about it, and then a bunch of other stuff. So in about 3 months, we'll get together on your half hour, and I'll return the compliment and thank you for everything that you've done and tell you a little bit about what we're up to.
I look forward to it.
Think about what we were talking about when we met 2 years ago, and that International NASH Day in 2020, and how far you've come is just breathtaking. So congratulations on all that, and just keep going.
Please join us again Wednesday evening when Stephen Harrison joins Jörn, Louise, and Roger to preview the upcoming NASH Tag 2023 conference here on the Surfing the NASH Tsunami podcast.